Bismillah ar-Rahman ar-Rahim. We will start session number 3 regarding the dyslipidemia. It's my pleasure to invite Dr. Muhammad Hassan from the Cairo University to start with how to achieve the target LDL in primary and secondary prevention.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. Firstly, I'd like to thank my dear professor, Dr. Magdi, for inviting me to present here in this excellent meeting as usual. So in my talk, I will highlight how to achieve the target LDL cholesterol in primary and secondary prevention of cardiovascular disease. As you all know that the totality of evidence from Mendelian randomization studies, prospective cohort studies, and randomized controlled trials support the causal role of LDL in the pathogenesis of atherosclerosis. And actually all these trials have consistently demonstrated the dose-dependent and linear relationship between the reduction or percent reduction of LDL cholesterol and the risk of cardiovascular events. Here, for example, this is a meta-analysis of more than 26 statin trials, including around 170,000 patients, that showed that we have at least 10% proportional reduction in all-cause mortality per 1 millimole, around 40 milligram per deciliter reduction in LDL cholesterol, and around 22% proportional reduction in cardiovascular events per 1 millimole reduction in LDL cholesterol. But it seems that the benefits are not specific for statin therapy, because now the data from non-statin therapy actually support also this. So, for example, in the IMPROVE-IT trial, the ezetimibe led to additional 20 to 25% reduction in the LDL cholesterol, and the PCSK9 targeted therapy in the FOURIER, the evolocumab, and the ODYSSEY trial, the alirocumab, and we have the inclisiran in the ORIENT 10 trial, achieve also at least additional 50% reduction in LDL cholesterol. And this is translated into a better outcome. In the IMPROVE-IT trial, we have additional 7% relative risk reduction in terms of primary endpoint reduction in the primary endpoint. In the FOURIER trial and the ODYSSEY, the two PCSK9 inhibitors achieved additional 15% relative risk reduction in the primary composite endpoint of cardiovascular mortality, MI, stroke, hospitalization for unstable angina, or coronary revascularization. So it seems that there is no level of LDL cholesterol below which benefit ceases. So the lower, the better. And even all this happen with good safety, and no adverse events happens related to the significant reduction, or actually reduction of LDL cholesterol down to 30 or even 20 milligram per deciliter. And we have data from FOURIER trial that there is no adverse events or serious adverse events happened with extreme reduction of LDL cholesterol and no affection of the cognitive function, and that lead to stopping the drug during the conduction of the study. And this actually make the European guidelines to adopt a new target, which is a 55 milligram per deciliter in patients with very high risk for cardiovascular event. This is a class 1 indication to achieve a target of 55 milligram per deciliter in patients with either for secondary prevention in all patients with atherosclerotic cardiovascular events, or as a primary prevention in familial hypercholesteremia, but he should have another major cardiovascular risk factor, patients with severe CKD with GFR less than 30, diabetes with target organ damage. So in all these patients, you should achieve a target below 55. And a target of 70 milligram per deciliter in patients with high risk group as a primary prevention if the calculated score between 5 and 10, markedly elevated single risk factor, thus with familial hypercholesteremia if there is no additional risk factor, CKD between GFR between 30 and 60, diabetes mellitus without target organ damage, and a target of 100 in patients with moderate risk. And actually there is a class 2B even recommendation to go down with the LDL cholesterol below 40 if the patient who experienced a second event or a second cardiovascular event, either myocardial infarction or coronary event within 2 years of the initial event. So there is a class 2B recommendation to go down with the LDL cholesterol below 40. But this is quite different from the American guidelines, because there is actually recommend for secondary prevention the same target, which is 70 milligram per deciliter in its latest 2018 guidelines in very high-risk patients. And actually, the definition of very high-risk group is quite different from the European and the American. The Europeans say that any patient with documented atherosclerotic cardiovascular disease is a very high-risk group. However, in the American, they say that they should have multiple events. So you should have at least more than one event to be very high risk, and if you had one event, so you should have multiple major risk factors, as we know, the elderly, if he has a heterozygous familial hypercholesteremia, or more than one major risk factors in addition to the first event that he has. And the American guidelines for primary prevention recommend a high-dose statin in patients with LDL cholesterol more than 119, even once the age more than 20. So once the patient age more than 20, between 20 and 75, and once we have an LDL cholesterol more than 190, so this patient should receive high-intensity statin. Diabetes, any diabetic patient aged 45 years or more should have at least moderate intensity statin. However, if there is some risk enhancers like long duration or any target organ damage, so this patient should receive high intensity statin, or if the calculated score from the pooled cohort equation, if the risk of or if the risk of cardiovascular events more than 20%, so this patient should receive high intensity statin. Importantly, if the calculated risk is borderline or intermediate, there is some risk-enhancing factors, either clinical or by imaging, just doing a carotid duplex to screen for the presence of carotid plaque or the coronary calcification or coronary artery calcium score. These patients actually, this help you to discuss with your patient the benefit from giving statin or LDL lowering treatment as a primary prevention for long term. What about children? Actually, there is a class 1 recommendation to screen for the children if there is suspicion for homozygous familial hypercholesteremia even from the age of 5 years. And we can start statin therapy from the age of 8 to 10 years. There is a class 2A recommendations in patients with familial hypercholesteremia to start from the age of 8 years statin therapy with a target LDL cholesterol. If the age between 10 and 20, so the target is 135 milligram per deciliter. So how to achieve? We know that the target for the patient, but how to achieve the target? We know there is a rule for non-pharmacological treatment, lifestyle modification, diet, low trans fatty acids, exercise, and weight reduction. We know there are certain foods to be preferred and other foods to use the moderation and to be avoided in those patients. But what about drug therapy to achieve the goal in patients either for primary or secondary prevention? Firstly, you should know what's the baseline LDL cholesterol for this patient and define the treatment goal based on the risk stratification that we have demonstrated. And you start high-potency statin according to the guidelines. They start with monotherapy to give a high-intensity statin, and they check the LDL cholesterol after 4 to 6 weeks and see the goal. And if the goal is not achieved, so you add ezetimibe as a class 1 recommendation and then reassess again after 4 to 6 weeks. If still you did not achieve the goal, so there is still, you can add PCSK9 inhibitor as a class 1 recommendation for secondary prevention and for primary prevention in patients with familial hypercholesteremia. However, there is class 2B recommendation, very weak recommendation for PCSK9 inhibitors as a primary prevention in absence of familial hypercholesteremia. But this is the guidelines. The guidelines is to start with the monotherapy, to start high-intensity statin, and then you add on other therapy if you did not achieve the target despite maximally tolerated statin therapy. But it's very important to see from the start whether, according to the baseline LDL cholesterol and according to the target, what is the expected reduction of LDL cholesterol? So we know that high-intensity statin will lead to around 50% reduction of LDL cholesterol. High-intensity statin plus ezetimibe will achieve 65% reduction. If you add PCSK9 inhibitors, so we will expect 85% reduction. So if you are from the beginning, actually, and this is some expert analysis or expert recommendation now, and I mentioned further, if you are expecting that from the start, from calculation that you will not achieve your target LDL cholesterol with a high-intensity statin, so a combination therapy from the start like hypertension is recommended. And unfortunately, despite what we are seeing from the evidence and from the guidelines, there is a large gap remains between the guideline recommended LDL cholesterol and the clinical practice. For example, here, this is the European-wide cross-sectional observational study to see the use of lipid lowering in secondary prevention and in the Da Vinci study. You will find that in patients with atherosclerotic cardiovascular events, they use a very high-risk patient, the 45% receive only low to moderate intensity statin. And in high-risk patients, around 70% of patients received low and moderate intensity statin, so actually did not receive high-intensity statin. Did they achieve the target in those patients? If we see here, in the very high-risk group, only 18% in the overall group achieved the new 2019 target, which is 55 milligram per deciliter. And around 39%, only 39% achieved even the target with 70%. This is in the very high-risk group. If you'll see here, the patients with secondary prevention, all this patient has either coronary disease, peripheral disease, cerebrovascular disease, you will see that actually the mean LDL cholesterol in this patient all actually above the European target, the 55, and even the mean is above the ACC target, which is 70 milligram per deciliter. Even this is data from the US to see also that the utility, actually, there is really in clinical practice large gap between the target LDL cholesterol and the utility. They do not achieve actually the target LDL cholesterol despite all this evidence. So here, for example, this patient with atherosclerotic cardiovascular disease, the use of high-intensity statin is only 40%. And which patient actually achieved the target? It's around 20% they achieved the target. So this gap actually started to think that you should increase you should depend more on patient education. You should educate your patient more about the disease, about the value and the importance of LDL reduction, either primary and secondary prevention, and also for the use of combination therapy. There are now many, many expert recommendations to start with a combination therapy from the start, like hypertension, to start with a high-intensity statin with ezetimibe from the start to achieve the target LDL cholesterol earlier, and actually to increase the percentage of patients that achieve a close target to the target for this patient with atherosclerotic cardiovascular disease. And even there is some recommendation to start even with triple therapy in extremely high-risk patients that have recurrent cardiovascular events. So very important also to know how to achieve your target in patients with a statin therapy. We know that some patients develop muscle-related symptoms, high CK, high liver enzymes. In patients who develop high CK, it's not recommended to stop the statin therapy or decrease the dose once it's just have some elevation. The recommendation is to see if there is elevation more than 10 times the upper reference. So this is really a recommendation to stop. But if you don't have symptoms and the CK is elevated even more than, even up to 10 times the upper reference limit, so do not stop as long as there is no symptoms, and just follow up, because it could be elevated due to exercise, due to muscle, just it's relief from the muscle. But if symptoms persist, so in this scenario, you can stop statin therapy and think of other alternative. You may initiate again after returning or normalization of CK and think of non-statin therapy. If the CK is elevated but less than 4, so definitely do not stop except after severe symptoms that you may think to shift to other statin or alternate dose. Even you can give statins twice per week in order to even take at least very small dose, but this is a maximally tolerated statin therapy, and you can add non-statin therapy like ezetimibe and PCSK9 inhibitor. The same for liver enzymes. You do not stop except after elevation of liver enzymes threefold the upper reference value, and then you will follow up the liver enzymes. So my take-home message that how to achieve the LDL or the target LDL cholesterol. Firstly, you should know what's the baseline LDL cholesterol for your patient. You assess the risk either for primary and secondary prevention, and establish what's the target for your patient, and you can expect the LDL cholesterol percent reduction to judge to start with monotherapy as the guidelines recommend, or there is some new recommendations even to start with a combination therapy. And then very important to assess early after initiation, not to ask the patient to see the lipid profile after 3 months. So you just evaluate after 4 to 6 weeks to see if you achieve the target or not. If you did not achieve, so you will add a non-statin therapy like ezetimibe or PCSK9 inhibitor. Thank you.
Thank you, Dr. Muhammad, for this elegant presentation for the guidelines. I have a question, please. If my patient achieve the target LDL by full dose drugs, statins, ezetimibe, up to PCSK9, for how long it will continue as such? Is it any possibility for de-escalation? As if I talk this, yani if it's a possibility to stop one of these drugs?
If you reach the stage that you added PCSK9 inhibitor, this means that you did not achieve the target on high intensity statin and ezetimibe. So once once you put PCSK9 inhibitor, either alirocumab or evolocumab or even the new inclisiran, you found an LDL cholesterol down to sometimes 30 and 20.
My question is how long to
you will continue. The recommendation
forever?
is to continue. You may remove the ezetimibe, but definitely you will continue the statins and you will continue the PCSK9 inhibitor because you added it. You did not achieve the target on the statin. So once you put it, so the recommendation is to continue.
Excuse me. On clinical practice or reality, reality, which is better for the patient, duration or dosage? We know that, and unfortunately, the price of the medications depend on the dose. And if I give the patient so expensive treatment, he will discontinue against his will even. Which is better? Because in my opinion, the duration of statin therapy will protect the patient regardless of the target which I want to. The guidelines, actually, it is a guiding, but in reality, I prefer to give the patient a longer duration in suitable medications. What's your opinion? You have more
compliance is very important. So patient education is very important to tell your patient that this is what you should do, and I should give the high intensity statin all the time. The data is this patient will benefit from a very low LDL cholesterol or the low LDL cholesterol if it's maintained during his follow-up. So both are important. You should achieve the low target and you should be maintained during follow-up.
Dr. Muhammad, thank you for your elegant presentation as usual. I have 2 questions. First, the lower the better. To which level? I saw LDL 15. Is it allowed or to continue or to reduce the dose? I saw 2 or 3 patients reaching very low LDL levels with the statin and ezetimibe. Is it better to stop or not? Or to reduce the dose? I will not stop. This is my first question. My second question is, what about if the patient develops side effects or intolerance to one of the statins? Is it better to shift to another statin or to stop and shift to the PCSK9? Thank you.
Very 2 important questions. We see this in clinical practice. The first question, we are expecting that this will happen once you add PCSK9. So it's important the indication. I added PCSK9 because this patient, his LDL cholesterol was high above the target. So I put this PCSK9 inhibitor and I know that this patient needs the PCSK9 inhibitor. The data from the Fourier and from the safety data say that there is no adverse events, even on the cognitive function. We are really worried of the LDL cholesterol below 20, really, in our clinical practice. But what I have اللي بعمله انا حقيقي ان انا I will not stop PCSK9. ليه؟ لان انا حطيته based انا عارف كويس قوي ان this patient I will not achieve the target من غيره. بس I may skip the ezetimibe, I may and then follow up ال LDL. لو أنا كنت بدي very high dose مثلا say rosuvastatin 40, so I'll downgrade to 20, but I will not decrease significantly ال statin. I may skip بس ezetimibe. لكن ال data that we have, the safety, it's very safe based on the data that we have. And to stop PCSK9 because the LDL achieved 20 or 30, no, because the mean actually LDL cholesterol achieved from the PCSK9 inhibitor trials actually reached 30, so we know this will happen. In statin intolerance, once the patient has intolerance either related to muscle symptoms, either related to elevation of CK or liver enzymes, I usually try another statin. I start with a small dose and then see it's tolerated and then will up titrate. Even if it did not tolerate this dose, I will go down to even atorvastatin 10 milligram, even give it every other day, rosuvastatin 5 milligram, even rosuvastatin every other day, so at least he will take a statin, even on a small dose. And I add definitely ezetimibe from the start because I know that I will give very small intensity, small dose, so I will add ezetimibe and then see. And now we have PCSK9 inhibitor also as a non-statin therapy.
دكتور محمد, thanks for your excellent presentation. يعني أنا عجبني الدسكشن لأنهم كلهم بيتكلموا عن نقطة مهمة أوي وأنا بشوفها كتير في العيادة. إحنا عارفين كلنا إزاي ننزل LDL. مفيش خلاف عليه. ستاتين ايزيتامايب بعدين بيسكناين والنيو دراجز. القضية زي ما دكتور كل الأخوة الزملاء قالوا إن في العيانين بعد فترة من حتى الهاي دوز أو هاي انتنستي ستاتين يوصلوا ل 40 LDL 35 و30. وإحنا برضو في نقطة بنقعد مع العيانين الريسك اللايف ستايل موديفيكيشن والويت ريدكشن والريجولار اكسرسايز والدايت كنترول اي ثينك بيلعب دور كويس قوي في العيانين المثقفين. ده نقطه زي ما بتقول. طب انا وصلت ل 30 بهايند ستانست ستاتين، سي انا بدي مثلا رزوفا 20، هل انا اكمل برزوفا 20 وانا فاكر وانا عارف ان عنده اللايف ستايل بتاعه اتحسن جدا وبقى سمارت كده بتاع، ولا اسيبه على 10 انا عندي لور ليفل معروف لكن ما عنديش بياند لور ليفل ايه الاكسبتنس بتاعه؟ فهو اعتقد كل الحوار امتى نقلل، مش هقول نوقف، مش هنقول نوقف لان عشان ناخد الاذر بنفيتس اوف ستاتين غير الريدكشن ال LDL، لكن امتى نقلل وده مسموح له ولا لا؟ اعتقد لازم ناخد بقى راي كل الناس، لان انا عن نفسي لما بلاقي واحد ب 20 مللي جرام رزوفه وصل 30 بقول له خد 10. ما اعرفش اذا كان ده غلط ولا صح، بس انا مقتنع بكده لان مفيش داتا تقول لي ان انا ما اعملش كده. فايه راي حضرتك في الموضوع وراي الدكتور مجدي برضه؟
طب نسمع راي دكتور مجدي
We know that the lower is the better. طبعا دي الكونسبت او القاعده المشهوره. If I have a high risk patient with established atherosclerotic cardiovascular disease, achieved LDL 30s, 40s on 20 milligram rosuvastatin, I will keep him on the same dose. I will not decrease the dose. Because the evidence from the studies proved that there is no harm at all, even achieving LDL up to 20. So I will keep him on the dose which lead to proper LDL reduction, even it is 30 or less.
حضرتك عارف ان الايفيدنس يعني الموضوع ده از تشينجينج اوفر ذا تايم. يعني الامريكان في وقت من الاوقات قالت انا مش هتكلم على تارجتس، I will give high intensity statin and that's it. فبالتالي high intensity statin I definitely I will not stop. لو ال LDL وصل 40 او 30 I will continue لان العين ده محتاج ال high dose intensity statin and I know from the safety
دوز مش مودريت انتنسي دوزج، مش شرط تبقى هاي انتنسي. ما حدش قال ان تو كيب ذا هاي انتنسي دوزج هي اللي بتدي الاذر بنفيت ابارت فروم LDL ريدكشن لغايه دلوقتي. في حد قال كده؟ حتى ريفرسال اوف اثيروسكليروتيك بلاك فيها داوت مع كل الستاتس اللي اتعملت على الايفوس. فاحنا عاوزين نكون منطقيين. دكتور مجدي انا موافقه طبعا، احنا ممكن ندي 20، انا ممكن اكمل وبعدين انزل بعد شهر اعمل له تحليل قال لي 10، اعتقد هقول له لا مش هكمل بقى دكتور مجدي، هضطر ادي 10. وانا احط احتماليه لو اديته 10 وبعد شهر بقى 60 هقول لا ده انا كنت غلطان انا وقفت، خلي 20. اي مين دي فيها نوع من لازم فيها some personal experience، وانك تقعد مع العيان عشان تعرف تحسن ازاي اللايف ستايل. وانا اعتقد احنا لما نبذل مجهود مع العيان انك تخليه يجري ويعمل اكسرسايز ويحسن اكله، ده الافكت بتاعه بيبقى مينتيند اكتر ما تديله دراجز.
هي حقيقه بس عشان الداتا ذات وي هاف ناو انه فعلا خلاص كل الستاديز اللي بتطلع لا كل ما بقلل ال دي ال كوليسترول there is a benefit. That's why حتى في الالجوريزمز بتاعنا ما فيش الجوريزم انه انا وصلت للتارجت طب انا لو قليت قوي بقى عن 20 اقلل، حتى they are not putting this. ليه؟ لان هم they are believing انه it's better، وفي نفس الوقت كمان ما فيش اي safety concern على اليوز اوف دراج.
دكتور محمد، بعد اذنك دكتور باسم، دكتور احمد، اخر سؤال يعني. ثانك يو فور اكسلنت برزنتيشن دكتور محمد. هو بس سؤال على العكس يعني، بس هو في البراكتس كومون يعني كلنا العيان بيجي دلوقتي مش شرط بريسك استراتيفيكيشن ولا حاجه، بنلاقي ناس كتيره ماشيين على ستاتين مجرد ان هو عمل تحليل فال دي ال بتاعه 120 130 موستلي يعني ما فيش لايف ستايل ولا اي حاجه، ما فيش، هو على طول احنا بنبدا على طول ستاتين، ما فيش فكره اللو انتنستي والمودريت تيست يعني. انا بتكلم على البراكتس الحقيقي، والعيان بيجي التحليل ال دي ال 120 130 بياخد ممكن ايفن زي ما الدكتور احمد قال رسوبه 20 او ايا كان يعني. فهنا برضو دي فيها كونفليكت رهيب يعني. وطبعا لما بيجي للدكتور التاني مجرد ان هو هيعمل داون جريدنج انت كده خرجت بره الاطار الطبيعي، ده انا كذا ده. فدي نقطه يعني مهمه جدا، فكره ان احنا الريسك ستراتيفيكيشن مين اللي يبدا ومين اللي ما يبداش، واللي يبدا ايه يعني. برضو ما هي ليها، احنا عندنا رولز كتيره، فدي نقطه يعني انا شايفها ديبيتابل كتيره، وده اللي شغال يعني عامه. في ابتو ان في ناس بتاخد بيسك 9 من غير ما يكون هو انديكيتد يعني، واي كلام في الاتجاه ده يبقى انت خرجت بره الرول يعني.
لا بس حضرتك فعلا يعني بنشوف ده كتير ان اور كلينيكال براكتس. بس حقيقه برضو انا بقعد مع العيان وبفهمه كويس قوي ان في حاجه اسمها ريسك اسسمنت، وخلي بالك التارجت اللي مكتوب ايفن اللي بيجي لنا من اللاب من كل اللابس ده is not true. لان احنا if you are patient if I'm putting stents for you actually انا هوصل بالال دي ال بتاعك below 55. لكن if you are moderate risk or low risk and you have LDL cholesterol from 2 I will not give you medication. It's a risk benefit. فما فيش اي benefit ان انت هتاخد دواء في الوقت الحالي، هو بس يمكن محتاج more education. لكن بنشوف ده كتير جدا جدا في clinical practice. فهي المهم مش ال LDL، لا هو المهم what's the target، وبعد كده هنبدا بايه. انا بشوف بقى هو البيز لاين قد ايه والتارجت قد ايه، اند ذن اشوف انا محتاج هبدا قد ايه، وكمان بيزد على الجايد لاينز. وحقيقه ده الاستيميت. يعني انا مثلا بشوف عيانين ال دي ال كوليسترول بعد مثلا بعد هاي انتنسيتي ستاتين وايزيتيمايب والال دي ال بتاعه 130 once he received PCSK9 inhibitor وصل 20. فانا وي بيليف ان في فاريشن، لان ده مثلا اكيد عنده جين اوف فانكشن في البي سي اس كي 9. فونس هي تيك ذا بي سي اس كي 9 انهبيتور فعلا استفاد جدا جدا من البي سي اس كي 9. فهو you estimate the risk based on the data that we have، وبتestimate ال expected reduction في ال LDL and then you will follow up your patient.
سؤال لو دكتور محمد، اولا شكرا على المحاضره القيمه دي. احنا اما يبقى في ستاتين انتولرانس وهنشفت على البيسك 9، هل البيسك 9 وزاوت ستاتين، ولا البيسك 9 وذ سمول دوز ستاتين، ولا البيسك 9 وذ سمول دوز ستاتين وايزيتامايب، ولا البيسك 9 وايزيتامايب اونلي؟ ايه اللي حضرتك تفضله؟ لان في ستاتين انتولرانس المريض اصلا مع اقل جرعه تبقى مشكله كبيره يعني.
حضرتك هو على حسب. احنا المهم ان احنا دايما نحط في دماغنا انه ان this patient should receive at least any dose of statin على حسب. يعني انا لما الاقي عيان عنده severe symptoms like this ببدا بفيري سمول دوز. ابدا مثلا ب يا اما 5 واقول له خد، هنبدا every other day for duration. لو ما عندوش اي symptoms اب تايتريت بعد كده. ف I will keep statins الا اذا it's not tolerated at all. على الاقل very small dose اغير الستاتين. لكن there is definitely benefit. مش هنقول يعني خلاص احنا we have solid evidence ان الستاتنز ليها دور مش بس ال LDL cholesterol reduction الانتي انفلاماتوري. فهي الاوتكم ترايلز كلها احنا لازم يبقى معانا ستاتنز الا لو البيشنت is not tolerating even ده حتى الجايد لاينز بتتكلم ريكومنديشن اديه مرتين في الاسبوع. يعني I can give him atorvastatin twice weekly مع الايزيتيمايب مع البي سي اس كي 9 inhibitor. بس you will not omit خالص الستاتنز except الا بقى اللي هو فعلا is not tolerating this dose.
شكرا.
Thank you, Dr. Muhammad, for this elegant presentation and guideline information. دكتور ياسر مش موجود تالي مش كده؟ دكتور ياسر بغدادي. Okay, now it's my pleasure to present my friend and one of the best lectures presenter, Dr. Haitham Badran, who will give his presentation about modern management of acute pulmonary embolism, state of the art.
Thank you, Ahmed. Thank you all. Thank you, Dr. Magdi, for the invitation. And before starting the presentation, I have an answer for this statin de-intensification or de-escalation. الحقيقة في one study published السنة اللي فاتت بس كانت على stroke patients. The de-intensification of the statin therapy associated with the increased mortality and recurrent stroke despite of the LDL level. فاحنا I do think it will go same with the cardiovascular effect. If we de-intensify the statin therapy, I think we should be at higher risk. Usually I maintain the same dose despite of the statin therapy. Thank you again for the invitation. Actually, it's a little bit different from the dyslipidemia and the myocardial infarction. It's about the pulmonary embolism. Management of the acute pulmonary embolism have seen some progression and change in the last few years, including the catheter therapy and the aspiration of the thrombus. So I'll go rapidly through the pulmonary embolism as a whole, as the diagnosis and the management, with this certain stress upon the catheter methods in order to treat the acute pulmonary embolism. This okay? So the pulmonary embolism, as we all know, is the third most common cause of cardiovascular death, accounting for something like 100,000 deaths per year. And I think this number is underestimated because a good number of these patients will die suddenly without discovery of the pulmonary embolism, as 1/3 of these patients will die before even receiving the first day of treatment. So the pulmonary embolism is a lethal disease, and actually it's very common. اللي بيقول إن هو uncommon, I think it's underdiagnosed because pulmonary embolism is common and is the third cause of the cardiovascular death worldwide. There was some data published in the European Society of Cardiology guidelines in 2019 indicated that although we have a decreasing mortality in the pulmonary embolism, but this was associated with also increasing the diagnosis. So might be the decrease in the mortality is due to the discovery of the new therapy, the catheter-induced therapy, and also the thrombolytics, but also because we use the CT pulmonary angio more frequently, so we have more diagnosis of subsegmental pulmonary embolism, which actually is not very life-threatening like the massive pulmonary embolism. So we have some sort of paradox. We have increase in the diagnosis, but we have a decrease in the mortality in the pulmonary embolism in the last few decades. So we have very strong predisposing factor. We all know it's like the cancer patients, the prolonged recumbency, the major surgery. All of these are strong predictors for the pulmonary embolism, especially if associated with prolonged recumbency. And they have divided the predictors into a strong predictor with odd ratio more than 10, and moderate risk predictors like minor surgery. It's something between 2 and 9 odd ratio. And we have the weak risk factor or weak predictors, which is less than 2 odd ratio, including the bed rest for 3 days, the presence of diabetes and hypertension, including one of the risk factors, and also increasing the age. The importance of knowing the predisposing factor, that we must know that we have some sort of patient-related risk factors, which would usually be permanent, and some of the other risk factors related to the situation. Usually these risk factors are reversible. And this is very important in order to identify the duration of therapy post-pulmonary embolism in this patient. So what's the pathophysiology? It's simply obstruction or interference with both the circulation and gas exchange, because the obstructing pulmonary embolism would create a very strong afterload, sudden afterload inside the right ventricle. This will be reflected in right ventricular dilatation, tricuspid insufficiency, increasing the right ventricular wall tension together with hypoxia, followed later on with activation of the neurohormonal system, leading to peripheral vasoconstriction, and in the late cases, we have a deviation of the septum toward the left ventricle, decreasing the cardiac output, and which will precipitate more to the, of course, the low cardiac output status and the shock status in the massive pulmonary embolism. It's very important to identify the hemodynamic instability in the patient with pulmonary embolism, and it can be identified with one of the following, either, of course, cardiac arrest and circulatory collapse needing CPR, the presence of obstructive shock with persistent hypotension, blood pressure systolic less than 90, or achieving more than 90 with the use of the vasopressor, and with end organ hypoperfusion, or persistence of the presence of persistent hypotension with blood pressure less than 90 or systolic blood pressure drop more than 40 milligram mercury, lasting longer than 15 minutes and not caused by new onset arrhythmia, hypovolemia, or sepsis. So the presence of any of these three hemodynamic instability indicate that we have an acute high-risk pulmonary embolism, and this will need an immediate reperfusion therapy. So the diagnosis, it's actually not very easy, because usually in the pulmonary embolism, you should have a high degree of suspicion in order to diagnose pulmonary embolism, especially in the ER. So the clinical presentation, it might be very variable, including severe acute dyspnea, but this is usually associated with the massive pulmonary embolism involving the main pulmonary trunk. But if the patient have some sort of subsegmental or peripheral pulmonary embolism, the dyspnea might be very mild or even with severe exertion. Also, the tachycardia is one of the pathognomonic signs of the pulmonary embolism, especially if massive, with some ECG changes, including S1Q1, Q3, T3, which is suggestive, of course, of pulmonary embolism in the setting of dyspnea. And then we have the assessment of the clinical or the pre-test probability using various scores, including the Geneva score, as I show in this presentation. We have a simplified Geneva score, including the presence of previous pulmonary embolism or DVT, the presence of tachycardia, surgery or fracture in the past month, hemoptysis, active cancer, unilateral lower limb pain, or the suggestion of pulmonary of the DVT, of course, pain on the lower limb, deep venous palpation, unilateral edema, and age more than 65. The Geneva score, if you have the modified Geneva score, if you have a score of 0 or 2, it's unlikely, but more than 3, it's the pulmonary embolism is very likely. Then we have D-dimer testing in the ER. The D-dimer is a very good negative test. If you have a negative D-dimer, usually you can rule out the pulmonary embolism, especially if the patient's with low pre-test probability. But if you have a positive D-dimer test, actually you might have a variety of diagnoses with the high D-dimer test. And this is in the new guidelines. You should use, rather than a fixed D-dimer test level, you should use a D-dimer test related to the patient age and the risk probability as well. And then we have the imaging, starting with the CT pulmonary angio, which is now the gold standard in order to diagnose pulmonary embolism, but with the risk of contrast and radiation exposure, and we have some limitations, of course, if you have elevated kidney functions or the patient is pregnant or something like this. And then we have the VQ scan either with a SPECT or without SPECT, and this is a very good negative test. If it shows that we have no defect in the VQ scan, the patient is not having a pulmonary embolism, you can, of course, omit the diagnosis of pulmonary embolism, and the SPECT actually increase the accuracy of diagnosis of the VQ scan, because if you use the VQ scan in the presence of lung defects in the X-ray, actually will give you mixed results, but by using the SPECT, it's more clear if it is actually a ventilation perfusion defect or a defect in the X-ray or the lung parenchyma itself. And then we have the pulmonary angiography, which is a very invasive, of course, tool in order to diagnose pulmonary embolism, and it's only reserved for the patient undergoing catheter-based therapies in order to treat a pulmonary embolism. The echocardiography is one of the very simple and easy method to diagnose pulmonary embolism, especially in the setting of the hemodynamic instability and in the ER. We have several multiple criteria in order to diagnose pulmonary embolism, or say it's more likely it's a pulmonary embolism, including enlarged right side, especially the right ventricle in the parasternal long axis view, dilated right ventricle with the basal RV over the LV ratio more than 1, and of course the famous McOneil sign, which is hypokinesia of the right ventricle sparing the apex, the flattened interventricular septum toward the left ventricle, the presence of distended non-compressible inferior vena cava, denoting, of course, volume load on the right ventricle, 60/60 sign, which indicates the presence of severe pulmonary obstruction or a massive pulmonary embolism, and we have a tricuspid regurg with increasing the RV systolic pressure, the presence of mobile thrombus traversing the tricuspid valve, or the decreased tricuspid endotapsy, of course, less than 16 millimeter, or the presence of decreased peak systolic velocity of the tricuspid aneurysm less than 9.5 centimeter per second. All of these criteria can diagnose or help in the diagnosis of pulmonary embolism, especially in the setting of hemodynamic instability, because it's available tool even in the ER. So this is the recommendation of the guidelines. When to suspect the pulmonary embolism with hemodynamic instability, you should, of course, do an echocardiography, and you can proceed to the CT pulmonary angio if feasible and the patient can tolerate it. If suspected without hemodynamic instability, you should use the validation criteria, including the Geneva criteria, and then you should start anticoagulation as soon as possible if there is no contraindication. This is for the CT pulmonary angio and the venous scintigraphy. The use of the lower limb compressing ultrasonography in order to detect the presence of DVT or not, of course. The MRA is not recommended in order to diagnose the pulmonary embolism routinely, of course. So after assessment of the diagnosis of the pulmonary embolism, you should assess the severity and the risk of early death or the 30-day death of the patient, including the clinical presentation, the presence of hemodynamic instability, of course, the echo criteria with the RV strain. The CT pulmonary angio can give you a picture of the size of the pulmonary embolism, whether it's affecting the main trunk or not. The laboratory findings suggestive of myocardial injury, including elevated troponin level, right ventricular failure, including the elevation of the pro-BNP, of course, or the shock state with the elevation of the lactate level. So we have also the pulmonary embolism severity index, which is either original version or the simplified one. Of course, I usually use the simplified one in order to diagnose the severity of the pulmonary embolism, including, of course, the age of the patient, the presence of cancer, the chronic heart failure or chronic pulmonary disease, COPD, of course, the presence of tachycardia and hypotension, the presence of hypoxia, less than 90% of oxygen saturation, and if you have more than 1 point, this will raise the 30-day mortality to something about 10.9 or 11% in this patient, in comparison to only 1% if it is 0 point in the modified score. So again, what's the treatment of the pulmonary embolism? At first, in the acute phase, you should support the hemodynamics and the respiratory status of the patient, including oxygen therapy, up to ventilation, but usually this will not work alone without reperfusion and maintaining the circulation. Pharmacological treatment of the acute right ventricular failure, I will show very rapidly. Mechanical circulatory support and ECMO will be the last resort if the patient is shocked and not responding to the oxygen therapy. So how to treat the right ventricular failure acutely? Actually, volume optimization until you have some sort of elevation of the central venous pressure. But this may contribute more to the compression of the left ventricle by the septum and decreasing the cardiac output. The vasopressor, including norepinephrine and dobutamine, of course, it helps in increasing the blood pressure, but also it might increase the peripheral vascular resistance, making more load at left ventricle and may increase the organ hypoperfusion. And finally, we can use the ECMO in order to support the right ventricle, but prolonged use of ECMO also is associated with multiple complications. The anticoagulation, you should start with the initial parenteral anticoagulation, even with the heparin shots or infusion, if the patient is highly suspected of the pulmonary embolism. The use of the unfractionated heparin may be of rationale or appropriate if you are going to use thrombolytic therapy or mechanical extraction. Low molecular weight heparin, fondaparinux, may be preferred if the patient will continue on this type of heparins. Not using the RTPO, of course, or of mechanical thrombectomy. Direct oral anticoagulant are preferred over the vitamin K antagonist, except if the patient have an antiphospholipid antibody syndrome, of course. The reperfusion treatment using systemic thrombolysis, actually it's very evident but associated with the increased risk of bleeding, and we have some paper or some data showing that the patient receiving RTPA, something like 3 to 5% will have some sort of intracranial hemorrhage, which is a very high percentage, of course. So it's a very beneficial way in order to regain the circulation and preserve the right ventricular functions and improvement of the hemodynamics, but with the expense of the bleeding. And we have also the reduced dose of the RTPA. You can give the half dose, and you expect similar result according to the papers and the guidelines, of course. And we have the percutaneous catheter-directed treatment, either catheter-directed thrombolytics in which you can deliver the thrombolytic therapy directly into the thrombus inside the pulmonary embolism in order to decrease the risk of intracranial hemorrhage or systemic bleeding. It's either ultrasound, using the ultrasound wave in order to lysine the fibrin threads and then inject the fibrinolytic therapy inside using the ECOS catheter, or you can directly inject the thrombolytic therapy by using a pigtail or direct catheter inside. And the second way, you can use mechanical thrombectomy or aspiration, like in the Minombra catheter, of course, plus or minus injecting a lytic therapy, and this depends on the size of the thrombus, of course, and the clinical status of the patient. And these are the type of catheters with the device available in order to do thrombus aspiration or mechanical thrombectomy for the pulmonary embolism. Surgical embolectomy, although it's not used routinely, but we have some papers that is associated with very good result regarding maintaining of the RV function and LV function at 30 terms in comparison to the RTPA, even with the RTPA. And this is a simplified algorithm in order how to treat the pulmonary embolism. If the patient is hemodynamically unstable, then you have a high-risk pulmonary embolism, and you should have immediate intervention or immediate reperfusion, either by systemic thrombolysis, by the catheter-directed thrombolysis or catheter-directed extraction, and you may use ECMO or right ventricular assist device. If the patient is intermediate risk, you should start with the anticoagulation, but you should have a very low threshold in order to use thrombolytic therapy or catheter-based thrombectomy for the high risk of the pulmonary embolism. This is a summary for how to diagnose and treat patients with pulmonary embolism, of course, and this is also when to discharge the patient. Actually, if the patient of low risk of pulmonary embolism, you can discharge on direct oral anticoagulant therapy directly to the home, but I mean, this is only in the low risk patient, of course. My final slide is for how long should we continue the anticoagulation for the patient with pulmonary embolism. Actually, it's a very crucial question because you are asked by the patient and the other physician for how long should you keep the patient on oral anticoagulation. Actually, at least for 3 months for all patients with pulmonary embolism, they should continue on oral anticoagulant. Of course, at the direct, if the patient is not antiphospholipid antibody syndrome. But if the patient have no clear cause of pulmonary embolism, or it's a recurrent DVT or pulmonary embolism, he should continue the anticoagulation for life. If the patient have a clear cause like a major surgery or recumbency for a long period of time, and this is reversible, he should continue until the cause is reversed. But if there is no reversible cause or a minor reversible cause, he should continue for long, more than 3 months, on the direct oral anticoagulant therapy, of course. I finished. Thank you very much.
Thank you, Dr. Haytham, for this excellent presentation. I have one question regarding your personal experience regarding the mechanical thrombectomy and when to use.
Actually,
and when to use, even theoretically. If the patient, I suspect, just suspecting with hemodynamic instability and these criteria, I'm going to take, and I'm having the mechanical thrombectomy, I'm taking the patient in hemodynamic instability to the cath lab in order to do it, or give thrombolytic, or do a CT angio. I want to, what are the steps to do?
So this is very important. This is a typical clinical scenario if the patient is presenting with shock and you suspect a massive pulmonary embolism. Actually, what we do in the ER, that we do an immediate echo, and if we have a suggestive sign of pulmonary embolism with no other causes of shock, and the patient has no contraindication for the RTPA, we should go directly for the RTPA because it's the fastest way. I mean, we will take time in order to prepare the cath lab and get the catheter and these things. So it's the fastest way to give a RTPA. But if the patient has some problem or contraindication for the lytic therapy, usually I take this patient to the cath lab and use, we have experience with the Minombra. We used it once or twice in the in Shams University Specialized Hospital, and also with the ECOS system. So both works fine, but in my impression, the RTP is more effective, actually.
So thank you very much,
Thank you,
Professor Haytham. Excellent presentation. So patient selection is very important.
Definitely.
So guided clinical, CT
So
pulmonary.
the diagnosis is crucial, and then after diagnosis, the classification whether the patient is at a very high risk or not. If the patient is very high risk with hemodynamic instability, reperfusion is immediate, either by RTPA or mechanical. And then, if not, if the patient is intermediate risk with elevated troponins only and signs of RV strain, but he's not shocked, you should start with anticoagulation, but with very low threshold to have a RTPA or thrombectomy if the patient deteriorates.
And the role of ECMO management.
Actually, the ECMO, I don't have experience with the ECMO in our facilities, but I mean, in the guidelines, the ECMO is reserved if the patient is still in shock, despite of the vasopressors and the fluids. He's still shocked, and there is a complete failure of the right ventricle. ECMO will provide, of course, hemodynamic support and oxygenation for this patient till we gave thrombolytic therapy, of course. Dr. Aisa.
فهو جاي بالبيت تاني يوم بري اوبراتيف اسسمنت للجراحه، بنعمل سي تي بالمونري، طلع في بايلاترال بالمونري امبولاي في المين بالمونري.
في المين
فوق فوق نو هيمودايناميك انستابيليتي، والمريض خد الفول انتيكوجوليشن. For how long we can stay until we go to operation?
Yeah, actually, it's very difficult. So, I mean, it depends on the type of the operation. What type of operation?
Fixation, fracture femur.
Actually, if the patient is completely hemodynamically stable,
Okay.
Without elevation of the troponins, I mean, he's a low-risk patient. If you have elevation of the troponins, I think you should wait until at least 3 weeks for the dual direct anticoagulation in order to get some resolution of the pulmonary embolism if the patient had elevation of the troponins. But if not, if he's a low-risk patient, I think he can go immediately to the surgery. If low-risk patient.
Do you recommend follow-up CT pulmonary?
I mean, it's not the matter of the pulmonary embolism. So the pulmonary embolism per se, if it is a subsegmental or something like this,
in a big branch.
If a big branch, usually it's associated with elevated troponin level.
Okay,
So I'll give this patient DUAX, direct oral anticoagulant, for at least 3 weeks, and then I think he will go to the surgery directly if there is no symptoms and no affection of the right ventricle in the echo.
Without CT.
Without CT.
Second question: do you prefer lytic therapy, الactylase, direct or systematic? يعني catheter guided or systematic?
Actually, if the catheter directed or the catheter directed is available, even by using a pigtail, I think it's better in order to decrease the bleeding. But sometimes it's very critical to transfer the patient to the cath lab, even from the CCU to the cath lab. It's very crucial. So you should give the RTPA as early as possible, whatever the route. Both of them are associated with increased bleeding, but I mean, the targeted RTPA is associated with less bleeding in the studies, of course.
شكرا.
زي ما حضرتك قلت excellent presentation. احنا كنا اتعلمنا من دكتور رمزي المواردي ربنا يمسيه بالخير، كان تملي كده ليه محاضره في البالمونري امبوليزم. If you will not suspect pulmonary embolism, you will not diagnose pulmonary embolism. فانت وضحتها جدا، فدي مهمه جدا للناس. انا بس السؤال هو انتوا في الثرومبوليتيك ثيرابي الار تي بي اي ده يمكن بالنسبه لي حديث حبه، انا عرفت التنكتبليز والاكتيليز من الاول، انتوا يعني هل الاكتيليز والتنكتبليز
اكتيليز اتس ذا سيم؟
ذا سيم. السؤال بقى انا عاود لما بتيجي تعمل ميكانيكال اسبريشن وبتدي ثرومبوليتيك ثيرابي، انت بتعدي الرايت فنتريكل بالمونري ارتري ولا بتخش لازم
ثرومبس
تخش البالمونري؟
احنا
بتدي قد ايه بقى ويتش ثرومبوليتيك؟
الحقيقه ريكومندد دوز الهاف دوز، وي شود جو ذا هاف دوز انسايد، احنا بنعمل كده.
يعني اللي انا اعرفه كان زمان يقولوا الوحيد اللي بيتاخد انترا كرونري اليوروكاينيز، كان اليوروكاينيز هو الوحيد اللي اكسبتد واخد اف دي ابروفال فور انترا كرونري. انا ما اعرفش السيناريو هيبقى موجود في البالمونري ولا لا، بس انا في تخيلي بس هتبقى البروبلم اذا دوزج اي حاجه ثرومبوليتيك هتنفع، بس المهم نعرف ويتش دوزج لاي ثرومبوليتيك هندي.
لا انا اقول لحضرتك يعني ماي اكسبيرينس،
يعني انا ما اعرفش عشان كده بسالك بتعملوا انتوا البروتوكول بتاعكم يعني.
we gave the actylase in half dose inside the pulmonary artery. وعلى فكره الستريبتوكاينيز was studied inside the coronaries، بيدوا 250,000 يعني بيدوا ربع الدوز، و it works يعني عليه studies ان هو it works في الهيفي thrombus burden. بس احنا بندي half the dose of RTPA inside the pulmonary artery لو احنا هندي inside، بس احنا لازم نخش جوه الثرومبس حتى الايكو سيستم ده بيعمل الترا ساوند، بيعمل يعني فراجمنتيشن الفايبرين ثريدز بتاع الثرومبس قبل ما تدي الليتيك ثيرابي. number is here. الايكس على فكره كان
Yeah.
موجود.
Thank you, Dr. Haitham.
you.
By this, we come to the end of session.